The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are gathered here today for the next episode of TMD Demystified. I am Tony Urbanek. And today's topic that I've chosen intentionally to follow the three prior episodes we did, which were TMD and the oral and maxillofacial surgeon, TMD and the orthodontist, and today's topic is TMD and the general dentist. A lot of the information I'm going to go over today and what I'm going to discuss is located within several of the other episodes that I've done over the past year and a half, and some new information or points of view also. But I thought that I would do this series as it applies to each of the areas of the profession of dentistry that apply to treating temporomandibular joint problems. And the general dentist actually is the most likely to treat or to at least see patients with TMD. And so this third episode in the series is devoted specifically to the general dentist, and I'm trying to bring all of the information together in one location as it applies to the general dentist. So although I may speak about topics or things that are relevant to an oral and maxillofacial surgeon or an orthodontist, within today's topic, I'm really directing it specifically to the general dentist. Just to recap the general nature of the whole podcast over the past year and a half is that we and I, starting 11 years ago, figured out what everyone else hasn't figured out about TMD and actually is ignoring. And to this day, it stymies me to think about how it's totally ignored in the different directions that professionals and providers are going on to treat TMD. And we'll just leave it at that for the time being. But I'm doing my very best to describe for my fellow colleagues in all professions, medical and dental, as best I know how, about getting them oriented on understanding TMD in the most simplified way so that they can apply this information so they can actually treat the patients predictably and correctly and get great results using a device that we had to call the Urbanek device for lack of better terms, which takes the load off the temporomandibular joint and a protocol to go along with it. All right, so let's begin. The general dentist is the most logical provider to treat TMD patients. We know that there's this entity called temporomandibular joint disorder. And I prefer to call it disorder rather than disorders because it all originates from inflammation within the temporomandibular joint. I'll repeat that for emphasis. The whole kit and caboodle originates, and all the symptoms originate with inflammation within the temporomandibular joint. That is the common denominator and the one fact and factor that needs to be fully understood and get your arms around it to follow through to any kind of treatment of this problem. And that's really the end all and be all of what I have to to teach. And once you understand that and the nuances of inflammation and the cell biology, a little cell biology of inflammation and a little neuroanatomy and things like that, it all falls together and makes sense. And you can quit doing some of the absurd things that are being used to treat this thing called temporomandibular joint disorder. So it's a disorder. It's a disorder of inflammation within the temporomandibular joint. It's not a multiple disorders. It's a disorder of inflammation within the temporomandibular joint. All right, so the general dentist, as it works out, I didn't create it, and it's just the way it's worked out. The general dentist is the most logical provider, because he gets the best access to patients with this problem in two directions. Whether it be the patient feels that he has something going on that might be TMJ, everybody calls it TMJ, including the providers. Whether it be originated by the patient himself or a provider out there, very commonly in the medical establishment, that says, I don't think you have headaches, Mike, I don't think you have migraine headaches, or I don't think you have Meniere's disease, or I don't think you have an ear infection. I don't think your ears are clean. They're beautiful. This must be TMJ. Go see your dentist. If I've heard that once, that history once, I have heard it 1,000 times plus. So it just works out that in the medical establishment and in patients' minds, if they think they have TMJ, they're going to go to their local dentist, not to the walk-in clinic, not to their PCP. If they get online and do something on Dr. Google, they'll be directed to their dentist. So it stands to reason that, let me get this so I can see how much time we have here. It stands to reason that the general dentist is the one who really needs the majority of influence, has the majority of influence, and needs the majority of influential information given to them so that they understand this problem. They see most of it. Now that we've talked about what really goes on there in the general dental office, whether you are right out of dental school, or you've been practicing for 30 years or longer, and we're able to work under what I call the golden age of the professions, golden age of dentistry, golden age of medicine, which we won't go into, but you probably understand why I call it the golden age, because basically you, the doctor, had control over what's going on. And now we don't, to the greatest degree, unless, although they want to tell you that you do, but you don't, which is another problem, which is another podcast. I'm not going to do that podcast. That's not my purpose in life. But the initial assessment of you, the general dentist, in seeing patients should include actually whether the patient has TMD. Why? Because it's extremely common. 45% of females have temporomandibular joint symptoms directly coming from inflammation within the temporomandibular joint. And for the umpteenth time, the symptoms, well established, well known, well agreed upon by everyone, of TMD, caused by inflammation within the temporomandibular joint, are frequent or recurring bad headaches, most commonly called migraines. Any bad headache is called a migraine. Frequent or recurring headaches, ear aches, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, vertigo, dizziness, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of locking. And if you are a progressive, knowledgeable dentist, whether 30 years experience or right out of dental school, you should be familiar with doing an assessment of your patient when they walk in the office, and not just treating a patient says, I have a toothache, and you treat the toothache and have them pay the fee and pat them on the head and say, good luck. just like a physician, a medical doctor, or whatever does an assessment of their patients when they come in, even if they come in for a specific reason, they include a general assessment of the patient. And your general assessment, because it is such a common problem, should include TMD. You're doing the patient a big favor, whether they ever seek treatment, whether they ever do anything about their symptoms. Nearly half the female population and a large number of the male population have one or more of those symptoms that they think they're either ignoring them, or they think they're coming from somewhere else, or they're currently under treatment by some other provider for those symptoms, which do not resolve because they're not resolving the inflammation within the temporomandibular joint. So you, the general dentist, are the most logical, available provider that, for the most part, the established medical system and the established dental system sends patients to for correction of these symptoms. Now, whether or not you can do that or not is the question. So, when I see these patients come in and they've been run around in a circle for anywhere between 6 months and some patients for 30 or more years. 20 years, 30 years is common around here for patients who have one or more of those symptoms, and they've seen 2 doctors, 6 doctors, 8 doctors. One patient said 150 doctors over a period of 10 years, going to doctor for these multiple disparate TMD symptoms. Nobody could figure it out. And total frustration. You can imagine the frustration on somebody who's seen 5 or 10 or 15 doctors, and that's not uncommon, to try to figure out these symptoms. So when they walk into your office, the assessment is actually pretty simple. Do you have any of these symptoms? And is the joint painful when you push on it? And I don't mean just push on a joint. You have to open widely, then push on the glenoid fossa, where the condyle came out of the glenoid fossa, and your finger can penetrate inside the glenoid fossa, and have them close rapidly. If they close rapidly and it hurts, the joint is inflamed. If the joint is inflamed and they have symptoms, they have TMD. It's that simple. And then if you have a Panorex, that's even more helpful, but most of the time doesn't show anything unusual, because inflammation doesn't necessarily cause bone degeneration in the early stages. Of course, when it's gone on for years and years, you will see changes in the anatomy, the hard tissue anatomy, the bony anatomy of the temporomandibular joint on a Panorex, which is very helpful. But again, you don't actually have to have that information. If you just have those 2 things, a good history and a hot joint, you have made the diagnosis. You don't need any machinery. You don't need an MRI or CT scan, although by the time they see you, most of the time they've had an MRI or a CT scan a time or 2 looking for brain tumors if they have chronic and recurring headaches. So, on the other hand, on the other side of this coin, is the general dentist is the least knowledgeable, for the most part, on understanding TMD and treating TMD. So they're the most likely to see the patient. You, the general dentist, are most likely to see the patient, and in almost all cases, the least knowledgeable about treating it, which is a shame, which is why I am doing this podcast series and why I'm doing this specific episode. So you're the least knowledgeable. So let me be very blunt and direct, unfortunately. Please stop with the night guards. That is not helpful at all. I'm not going to go into why you're doing that. You should not do it. A night guard is a night guard. It has nothing to do with treating TMD. and there's no doubt a night guard can be valuable if the patient is breaking their molars. And we see it all the time. Patient will break a molar because of the chronic bruxism and severe strain pressures they're putting on their posterior teeth. I mean, hundreds and hundreds of pounds of pressure, of load. Certainly break the cusp off a tooth. So a night guard is fine if you're protecting the teeth, and no problem with that. That is the reason for a night guard. But to give a night guard, whatever kind of night guard it is, to a patient and say, this is going to keep you from bruxing, which I've heard 1,000 times. Dentist gives the patient a night guard and says, this will keep you from bruxing. No, it won't. We do not understand the mechanism for bruxing. There's nothing I can say that is certain. There are a lot of theories about bruxism and how that affects and what's going on in the central nervous system in the level of the brain stem. We know that's where things are. The only thing we know about bruxing, it is related to stress. The more people brux. Half the population bruxes. Most of them are not aware they do it. Many of them are aware they do it. Whether they're aware or unaware they do it, we do not understand the mechanism. There is no on and off switch. The patient has no control over it. And we do not even we do not even have a good definition for stress. So the only thing we know is that bruxism is related to stress. The more bruxism. Of course, you can decrease stress. I talk to patients about that all the time, but that is a very nebulous thing. They know, we all know, that we should and how to decrease our stressors in life, but we all have them. There is no way to avoid them. And when the stressors get to a point where it affects the central nervous system and that mechanism there that we don't understand, that you start bruxing, it's habitual. You can have no control over it. It can happen night or day. It can be grinding, or it can be just clenching. It's all the same. So, but stop with the night guards, please. For whatever reason, certainly, I hope you're not doing it just for financial reasons. Be honest with the patient. Say, we do not understand bruxism. We know it's related to stress. Secondly, stop with this is too complicated to understand. That's my point of this, addressing you, the general dentist. This is not a complicated scene. The textbooks want to make it complicated. The teaching establishments, the dental schools, even recently, as my investigation has shown me, want to make this a really complicated problem. They bring in the physical therapists and the psychologists to talk about to talk about stress, and stress causes bruxing. And they all know that sitting down with a patient and talking to them about stress, I can do that just as easily as a psychologist can do it, and say, clean up your act, try to get rid of your stressors as best you can, cut down on the alcohol, get decent sleep, cut down on the sugar and carbohydrates. They're physical stressors. They are physical stressors. And sugar is a known inflammatory agent. So, you can talk to the patient about that, but, easier said than done. But no matter how much you try to cut down your stressors, you're going to still brux, especially if you have a history of bruxing. Once a bruxer, always a bruxer. So, but stop with the attitude that this is a really complicated problem. Please, this is not a complicated problem. This is understanding inflammation within the temporomandibular joint and the effect of inflammation, which directly causes each and every one of those symptoms that I mentioned. Part of your assessment, your original assessment of a patient, whether it be the first-time patient or a recurring patient, can be delegated to your hygiene in your hygiene department. And I have a whole episode on why that should be and how that should operate, because obviously a general dentist is the most likely provider to see the patient, and within the general dental practice, your hygienist is has the most access to all of your patients. And there is no reason that your hygienist or hygienists, plural, cannot do a 90-second evaluation history and examination. Anyone can do this exam. Patients can do a self-exam. In fact, it can be self-exam, but the hygienist can learn how to do it very briefly. A couple minutes, takes 30 seconds to do the exam. And they can rule out TMD for each and every one of your patients. Regarding that, you can't imagine how grateful patients are, many patients are, to find out that what they've been struggling with for years isn't migraine headaches and isn't Meniere's disease and isn't chronic ear infections, and it is TMD, which is easily treatable by unloading the joint adequately over a period of time with a device that they can use consistently. You have to start out 24/7. That's part of the protocol. We won't go into that anymore. But use the device that unloads the joint over a period of time according to the proper protocol, and a device that you can actually talk with and keep in 24/7. You do have to take it out to eat in the first couple months of the protocol, that you can talk well with it in your mouth, that it's not obvious and comfortable, and that you can wear 24/7. So literally every hygienist in your hygiene department within your general dental practice should be educated on doing this examination and history, which will bring these patients to light and for their benefit. And again, if patients feel that the symptoms associated with this diagnosis of TMD, once diagnosed, if it's not a bother to them, then it's not a bother to you. I tell patients all the time, look, if these symptoms don't bother you, they don't bother me. It's all about getting rid of the symptoms. And if the symptoms bother you, then I would recommend treatment. It's really simple. It boils down to that. So one of the other factors that comes into now treating TMD is distinguishing between the three causative occurrences that actually cause the inflammation within the temporomandibular joint. And again, super simple concepts. Inflammation is the common denominator, but there are three occurrences that actually cause inflammation within the temporomandibular joint. The first one is bruxism, the most common. The second is acute trauma. Saw a patient yesterday, Monday, with a really obvious history of early, at age 10, significant trauma to the maxillofacial region and temporomandibular joint. She actually had a Lefort 1 fracture at age 10 secondary to a motor vehicle accident, and she had significant growth discrepancies of her midface because of that maxillary fracture, which apparently was not treated correctly. Won't go into that. By her history, it didn't sound right to me. But now, years later, at age 30, has significant temporomandibular joint problems and symptoms associated with acute trauma. And then the third is what I really wanted to emphasize in this discussion here today, and that is functional malocclusions and the general dentist observation and delineation and differential diagnosis of functional malocclusions. Now, what is a functional malocclusion? All right, this is my definition. I don't need to argue it about anybody. It's my definition. If you don't like my definition, it's okay. But it works. It's a definition that works on applying this technology to thousands and thousands of patients. A functional malocclusion is any occlusion that creates a significant centric occlusion, centric relation discrepancy. What is the definition of significant? Well, that can be an inch between CO and CR. Significant mandibular prognathism, a significant midface deficiency, like the patient I saw yesterday, or it can be a matter of a millimeter or two in between centric occlusion, centric relation, but functional malocclusions. And again, there's an episode, I believe, that I went into a lot of detail about functional malocclusions and centric occlusion, centric relation discrepancies. But again, this is in your wheelhouse, being able to look at a maxillary arch and a mandibular arch and to see whether they equate, whether they match up. And if they don't match up significantly, then you have a functional malocclusion. And again, the definition is a CO-CR discrepancy of adequate size that causes TMD symptoms. So that differential position of the maxillomandible can be large or can be very small. And even if it's very small, it can cause inflammation within the temporomandibular joint. And then it's up to you, the general practitioner, to decide, well, is this something that I would want to treat myself? More and more general dentists are doing orthodontics on their own, which brings up the aligner issue, which I'll speak on in a moment. But it's whether or not you want to tackle that CO-CR discrepancy or functional malocclusion, or whether you want to refer it out to the oral and maxillofacial surgeon if it needs orthognathic surgery, or the oral or the orthodontist and oral and maxillofacial surgeon, or just an orthodontist. And hopefully we talked about the orthodontist responsibility in discerning functional malocclusions that need orthodontics alone, or those that need the assistance of an oral maxillofacial surgeon with orthognathic surgery. But nowadays, in the 2022 era of dentistry, aligners are being used almost across the board in almost all practices. And aligners are not built. The whole concept of using aligners is not based on correcting functional malocclusions. So it's a very tenuous set of issues, whether or not, if you're going to use aligners, whether you're even going to treat a functional malocclusion. The state licensed orthodontists that okay or approve aligners, or are supposed to approve aligners by state law, and all the aligner businesses, and there are now, I don't know how many aligners there are. It seems that somebody's entering a new set of aligners every day now. I see names I've never heard before. So there must be 30, 50 different sets or more set of aligner companies. But I can tell you that these aligners are not built, not supposed to at least, and not able, because of the way the access to the person who approves the aligners, to actually treat a functional malocclusion. And functional malocclusions are the third set of circumstances, third circumstance that actually creates inflammation within the temporomandibular joint. And the general dentist, you, doctor, need to be aware of these facts. If you're going to use aligners, you need to be aware of using your judgment to determine whether there is a functional malocclusion, and then use your judgment as to how best to treat this functional malocclusion, whether you want to get involved with it or we want to refer it out to one of your specialty colleagues. All right, and then the last part of this has to the TMD and the general dentist is really what the obvious value is for you, other than the value of your patients, and that is it actually brings in a significant increase in traffic into your practice. If it's easy to get a reputation for treating TMD successfully, we know how to market this from our company. TMJ Services has actually, once we got through the clinical knowledge that we needed to do, then it really got into the marketing area and how best to market it. And it's best marketed to other doctors who misdiagnose it, mistreat it, misdirect it, not to the general public. Although we talked about marketing it within your own practice, your hygiene, your assessment. But it is best marketed to the doctors who either don't want to treat it, which is okay. That's not for everybody to treat TMD. You have to have an interest in it. You have to want to do it for your patients. The medical profession has no interest and no knowledge about doing this. They want to get it off of their plate. And around here in Middle Tennessee, our medical colleagues are becoming extremely knowledgeable in their ability to differentiate between migraine headaches and Meniere's disease and chronic ear infections and TMD. So it's a huge practice builder once you begin marketing it correctly and get that reputation, and you increases traffic. The patients are extremely happy that they now have a solution to their problem, and they bring in their friends and bring in their family because they think that you are the best doctor that they've ever seen. You solved the problem that was before unsolvable for them. So it increases traffic, it increases satisfaction, and from the patient's point of view, and obviously increases your income. Sorry for the telephone. I meant to turn it off. So that's what I have to say directly to my general dental colleagues. I hope you take it in the spirit that it's offered, and that honest information from my heart. My goal is to see as many of these patients treated properly throughout the United States as possible. It is such a big problem, and we know it because we see it so commonly here now. Here in this particular practice, I think I've mentioned it before, but in Middle Tennessee, we have approaching now 800 unique doctor practices of all kinds, medical, dental, that refer this practice patients for temporomandibular joint symptoms, which is unbelievable. We add anywhere between 8 and 18 new providers per month sending us patients. These are new providers that we have never seen before. So I don't know how many providers we have in Middle Tennessee, but this practice has over 800, and our practice is totally devoted to the non-surgical treatment of TMD. I hope I've made my point to my general dental colleagues. I love you very much. I think you guys deserve the help. I think you deserve the ability to treat this problem. You certainly can treat it. All you have to do in our circumstance is take a 3-hour online course, get licensed to do it because it's a patented device and protocol. We'll teach you how to do it. We'll hold your hand for a while. We'll make sure you're up and running. And we're trying to disseminate this throughout the United States and beyond, for sure, to solve this problem nationally and internationally. I always appreciate your attention. I appreciate you sticking out here to the end. I encourage you to contact me with any questions or criticisms. I can be easily reached at tony@tmjservices.net, our Director of Marketing and Education, Naomi, at naomi@tmjservices.net, and our website directed to professionals, especially general dentists, oral surgeons, and orthodontists who want to participate in treating TMD simply and effectively and predictably with honestly great results, is www.tmjservices.net. For today, I am Tony Urbanic, and this is TMD Demystified.